My name is Michael Kluger. I'm with Altaris Capital in New York. We have $1 billion of private equity funds solely dedicated to healthcare investing, and one of our themes is digitizing and healthcare IT in general, a good chunk of what we do. We're lucky enough today to have three panelists with us. We've got Jacob Reider to my immediate left, Peter Hudson in the middle, and Chris Powell furthest from me on the left, and I'll let each of them introduce themselves. Jacob, if you would be so kind.
Simple family doctor. I grew up in Boston, live now in Albany, New York. I was in the, so I was a CMIO at a hospital, so I implemented hospital IT systems, and then I went to an ambulatory setting for 5 or 6 years and did health IT for a 140 physician primary care group. And then I got really pissed off because our EMR sucked. Raise your hand if you've heard that EMRs suck. So I joined the industry and led the clinical arm of a reasonably large health IT vendor for a couple of years. So did that for 5 or 6 years, and then this meaningful use thing came about. Raise your hand if you've heard of that. Not too many, so we'll have to fill you in. So $20 billion of federal investment that regulated the health IT industry, and that regulation sucked. So I got really pissed at the federal regulators, and then I became one. And so now I work for the Office of the National Coordinator for Health IT, which is the agency that regulates health information technology in the United States, and that's why I'm here.
I'm Peter Hudson. I'm a ER doc by training. I've practiced in a lot of different environments, from the knife and gun club area that I trained in Oakland to in the military, community-based systems as well, and was frustrated along the way with occasionally seeing the system break down in the emergency department. That is a joke. Almost every day, struggling to try to make things work better. And so I've been a serial entrepreneur building technology companies since the late 90s. Worked in investment banking for about 3 years prior to my starting the last company, iTriage. And with iTriage, went from concept on a piece of paper to exit to Aetna in about 2.5 years. And I've been with Aetna now for a 1.5 years, growing the company internally.
Good afternoon. I'm Chris Powell, president of Precyse. I started my career with a software IT company, IDX Systems Corporation, and then moved on to GE Healthcare, and now with Precyse. So I was probably one of those guys that provided one of those EHRs you love so much at one point. Precyse is basically an information aggregator. Between the white space of EHRs and the revenue cycle, there's this world of coding and clinical documentation and a lot of data. And we really work to make sense of that data by organizing and aggregating that data.
Okay. Well, thank you, all three of you, for being here today. Digitizing the American healthcare system, Jacob mentioned the federal government's made quite a commitment. $26 billion committed to rolling out EMRs and to digitizing the system. Jacob, maybe starting with you, how would you assess the nation's effort? What's gone right, what's gone wrong? Are providers embracing this? And are we going to get the yield out of this expenditure as we hope?
Last question first. I don't know. We sure hope so. I thought I'd describe a little bit about the program. The program was envisioned to be 3 stages. The first stage, which is the one I complained about, was in the High-Tech Act, which was part of the Recovery Act of 2009. So what that described was a framework of 3 stages. The first stage is adopt. So in 2009, somewhere between 20 and 30% of hospitals and healthcare providers had adopted EHRs in their practices. And so in order to do the better things with health IT, we needed more of the community to adopt. And so by this December, most projections put the mark at about 75% of hospitals and 75% of practices. More like 85 to 90% of primary care and fewer in specialty practices. And again, in hospitals, very sophisticated academic medical centers, it's going to be 100%. Critical access, small hospitals in rural settings, more like 50%, but 75% overall. So the first stage is adopt, and the first stage runs from 2011 until 2014. So we're still in, to answer some of Mike's question, we're still in adopt. The second stage is exchange, and the third stage is improve. And improve is improve outcomes, improve the quality of care, improve the efficiency of the care delivery processes. So I think Chuck mentioned earlier, that's the triple aim that we often focus on, right? Improve quality of care, improve efficiency, and reduce cost. So that's the nirvana of stage 3. We're approaching stage 2. So in stage 2, we have much better health IT standards. These systems have to use the same languages. They have to use the same protocols to interact with each other. And the companies are building that functionality today to be certified under our certification program. So where are we? We're starting. We're getting to stage 2. We're getting to better interoperability. The Medicities and the Axolotls of the world are going to facilitate that, but also we've established standards that will allow these systems to send information point to point, much like email. In fact, using some of the email protocols, but in a more secure way. So providers can send messages to each other. Patients and providers can and actually will be required to send messages to each other.
Thank you, Jacob. I think it's important for those of us who invest in the healthcare information technology space to manage the expectations, not just the managers managing the expectations of the investors, but really of the general public, which is paying for so much of the wiring of the system. So I think Jacob's laid it out, kind of a three-pronged approach. I do think we're well into the first prong, the first phase, but in terms of quality and getting to the next step, maybe Chris, you could talk about your experiences and some of the upcoming initiatives that providers are going to be wrestling with. And do you think that that starts to move us into this next phase where you're actually going to start to see improved care? And how is that done digitally, and how does Precyse and how do you fit into that?
Yeah, Mike, and I think what Jacob mentioned, moving into the stage of standardization, there's October 2014, a new procedure, coding lexology goes into play called ICD-10. And who's heard of ICD-10? I bet not too many. All right, so basically, to frame the challenge that healthcare has beyond meaningful use, beyond making use of data, basically right now when you go to the doctor, your care is coded in ICD-9 procedure code. There's 17,000 roughly of those codes. ICD-10 provides much more specificity and blows that out to 140,000 codes. Think of the impact that's going to have on physicians and their ability to code and the infrastructure of hospitals. There's been studies that have said that impact can be anywhere from $100,000 to a physician practice to multi-million dollars for healthcare systems. So the challenge is, how do we help transition the physician community and the people that code care for revenue cycle reimbursement and improving that quality with ICD-10? Because at the end of the day, what you're doing is getting more details around the care that's delivered, which ultimately gets to the questions of driving better care. I think Chuck talked about analytics as an example. Right now, there is so much unstructured text in medical records and in healthcare. Until we have technologies that can make sense of that, ICD-10 helps do that, but then there's a bunch of other text, free text, and data from other systems. There are technologies like we use, for example, natural language processing that move structured and unstructured data through an engine and give it meaning. And that's really going to help drive care. Good example, West Nile virus, right? SARS was one of the outcomes of West Nile virus. There is not an ICD-9 code that represents SARS. So think about population management and the ability to look across health systems and communities. If you can't have specific codes that represent care across the continuum, you're really at a disadvantage. So technology is going to really bring that to the next level, Mike.
I can't emphasize enough that for those in the room who are make their living deploying capital, equity, and debt into healthcare IT companies. Those companies that are in what Chris just described, the data aggregation, the making the data relevant so that it can be used, these companies are likely to experience very rapid growth. Before we get to Peter, Jacob, would you, kind of comment for a moment, how would you say the government feels about both data sharing, and when I say the government, the Obama administration feels about, because those are two different things, I see. But would you comment a little bit about the sharing of data and the need for data aggregation technology, such as Chris has talked about? I mean, do we have congressmen who mistakenly think that by spending in phase one, we're going to end up with an improved healthcare system? And what do you think about this next phase? What are the kinds of businesses and opportunities to make it all work?
So I'll start with the second one again. Mm-hmm. I think there have been expectations that have been expressed that why aren't we there yet? Why haven't we started to exchange data? I went to my doctor and he didn't have the results of my hospital admission from 2 weeks ago yet. Why is that? Or my cardiologist didn't have my primary care physician's note from yesterday. So there's an expectation that we've made these massive investments in adoption of health IT, and yet we're not moving the information back and forth in as fluid a fashion as we can. So I think there's an expectation that we're there yet when we're not. I think when we do this next year, Zabin, I hope to be able to talk about how that data has started to flow. And so once the data flows, I would agree with Chris and the softball you tried to throw me, Mike, the ability to catch, which the systems generally don't yet have. And so if there's white space there and lots of opportunity, it's in the standards that we have put in our regs to say, hey, you EHR systems, you need to be able to generate this standard thing. So if anybody is familiar with RSS, really simple syndication. It's an XML format. Now who's heard of Flipboard, right? Flipboard wouldn't exist without RSS, right? Because Flipboard took this butt ugly, XML and made it beautiful and accessible to my mom and Zabin. So because he was one of the few violently nodding. So it's what you do with the technical standards. And so we've established these technical standards. They're the raw materials for robust information acquisition and sharing. And so I think there's a great opportunity for both how to catch data. I met with a payer recently, and they said, so how are we going to get all this clinical data from all these systems? And I said, well, use these standards that these EHRs have to generate. They had no idea that, A, we'd put these regulations out to make the EHRs required to do it. They're used to going in and trying to suck the data out by hand and creating ETLs and all of the stuff that one or two folks talked about this morning, Chuck mentioned. So you won't have to create ETLs. You won't have to do this manually, and you can start to do it at scale. So now in a whole community, everybody can, if you're the payer and you want this clinical data instead of claims data, put in your contracts that your EHRs need to, the providers' EHRs and the hospitals' EHRs need to generate it, catch it. We would love to see that happen. And then once you've caught it, how do you make sense of it? What are you going to do with it? How are you going to turn that data into knowledge? And then the last piece, so this is the three-part answer, right? Catch, analyze, and then what do you do with the byproduct of your analysis? You've got to send that knowledge back to the providers. You've got to and the patients. And this is clinical decision support. And often in the health IT space, people think about clinical decision support as an alert. Right? So we're going to hit the doc on the head with a 2x4 and say, don't prescribe this medication that the patient's allergic to. But it's much more than that. It's this patient needs a this. And we've learned that the patient is actually the best conduit for that. Right? So it's through the patient. It's through the payer. It's the consumer decision support in addition. So once you've done the analysis, send that information back to where it's going to be leveraged and help folks make the right decisions.
Mike? quick comment on it. I think that's a really important point because you've got all this data in healthcare sitting in these vessels called EHRs or other places. And when it's finally through the process and billed and it gets to the payers and they do all the analysis, which is great analysis, what is it? It's retrospective analysis on care that's already been delivered. Right? What we have to do is get to the point where the technology analyzes that data, tags it appropriately so the physician can do something more real time and impact the care of that patient, especially if it's a chronic patient over time. Claims data is great. It gives you a look back. But how do we get more current with it?
The entire disease management industry, utilization review within the managed care companies, we know many of these names, some publicly traded companies, they all drive off of the claims data. And being able to manage the care at the point of care and making the data relevant is critical. So that, sort of looking at it, I think the way the four of us look at it is there's this first phase where the government has helped us digitize the front end. That's phase one. Chris is talking about the next step, which is billions of bits of information flying around. What do you do with it? There's information in the cardiac cath lab, at the MRI, at the lab, the EMR, the physician notes. How do you pull that together and make it real time and provide analytics around it? That's sort of phase two. There are a lot of investable opportunities in that space. There are a number of companies emerging, and it's a very exciting space. It's sort of where the EMRs were 8 years ago, 10 years ago. There's a real opportunity in this second phase that Chris is talking about. Ultimately, though, you need to do something with the data, and we have another member of our panel who's perfectly suited to talk about that. Peter Hudson, maybe explain what do we do with this information? Eventually, I think medicine has to do with people and consumers and getting them to make decisions. And how would you look at the first two phases, and what are the challenges and opportunities around the consumer part of this?
Yeah, great question. As I think about healthcare IT, technology-enabled service companies, we can invest, build, scale, grow these companies, but unless we involve the consumer systemically, we're going to fail ultimately, because consumer choice ends up driving a lot of cost, a lot of inefficiency, and a lot of problems in the system. We recognize that after practicing for about 20 years and seeing about 2 patients an hour. I think we saw 50,000 patients in all. And witnessing people struggle with core, medical information. A 70-year-old with chest pain going to the urgent care, coming in with, a heart attack and bad outcome because they didn't go to the ER first. And when I asked him, why'd you do that? He said, well, it's cheaper. So he made a decision based on cost instead of clinical information. Somebody coming in with, a tiny little abrasion on their ear from shaving in the emergency department. So, those were not uncommon things to see day in and day out. And so, as we started thinking about how the consumer engages in healthcare, we saw all sorts of consumer engagement technology out there that wasn't very well distributed. We saw lots of technology out there that was very well distributed, that was really focused on advertising and helping the last panel's products get distributed. But it wasn't solving core fundamental needs that consumers had. And after about 20 years, we figured out there's a problem and wanted to build a solution that was really a utilitarian technology-based solution for patients. Really targeting a couple different things. The information you need before you get to the hospital, before you decide to go to the doctor, before you take action on your care, the information you need to think about it in a rational sense. I'm sure we all have somebody that we know that when they get a headache, they think they have a brain tumor. And so that concern and lack of knowledge tends to drive a lot of visits to different places in the healthcare delivery system. Second, when you do need to go, what is the right level of service? So a contextual search and decision support layer that helps you figure out, does an urgent care suture lacerations? Does it have an x-ray? Can that take care of my ankle injury that I don't know if it's a sprain or fracture yet? And then once you get to, I know I need an urgent care, it's more convenient, and it's probably going to be cheaper. Where are they? A lot of people don't know where anything is around them. And Before we started the company, I had 3 people come to my front steps and with different medical problems, and it was really interesting. It really helped us focus on really 2 things. What could be causing my problem, and where should I go? And despite living in our neighborhood for 10 years, most of them had no idea that there were urgent cares or lower cost options. They didn't know which ERs were efficient, which ones had specialty functionality for the things that they were suffering from. So taking that information, building a navigation system was really the core principle of what we wanted to do. And interestingly, nobody had really done that. People had done symptom checkers, people had done provider searches, and certainly providers, and we'll talk about that I'm sure later, but weren't great at marketing and getting the word out about what they do. And payers, obviously, we're trying to drive engagement for very specific reasons, which may not make a lot of sense to the general consumer. So then as we built the technology, we really focused, I think we're kind of lucky that we're ER docs, because we never wrote long, beautiful sets of orders, taking a half an hour to really cover every single contingency that a patient might have. We'd go give a little squirt of morphine, run out the door, come back, see how they were, and keep checking. And that's really the philosophy that we built the culture of our company and the culture of the engineering group that builds our technology and the product group around, is rapid iteration. We had 97 releases last year to the marketplace. Lots of feedback, and fortunately focusing on mobile first, which we thought was critical for engaging people in a ubiquitous, utilitarian type technology. You get a lot of reviews and feedback, so if you screw up with your technology on a release, you hear about it in about 10 seconds. And the reviews start coming in and you figure out that something's wrong. So I think that kind of culture is really important as you build consumer technologies. And I see a lot of big companies saying we need a consumer or a retail effort. Unless you have that culture, you're going to just have technology in a space, in a sector like mobile, that is supposed to provide a brand experience for consumers, but will not be adopted and will certainly not compete for consumers' attention when they can go to Twitter and Facebook and all the other options out there.
Thanks, Pete. I mean, I think iTriage, which is now owned by Aetna, as Peter explained, they've been making tremendous progress. I think you have about 10 million connected consumers, which is a staggering number in a short period of time. What are the challenges in getting the rest of us connected? Or can this be a provider-driven phenomenon, or does it have to happen from the payer or a federal initiative, not unlike the EMR, to get it to go from where it is today to really ubiquitous in such a way that we can truly use it to manage the care in the country?
Well, I think when we started out, we thought that we have something we call a 3 Ps, so patients, providers, and payers. And if any one of those 3 participants in this ecosystem hated your technology, you probably were going to fail in some way, shape, or form. And so we try to look at what are the overlaps. And if a patient can go to urgent care, retail clinic, or telemedicine, all the different options that are cheaper for acute care, or go to an in-network physician, it's more convenient, it's probably faster, it's lower cost if they're at risk for some of that. So the payer wins, the patient wins, and so how does the provider win? And what we've really focused on from the very beginning is helping to drive market share for providers in an area for the things that they do well. And we focused really on core drivers that we think consumers will use, and that's essentially human nature. If you have more information about one provider than another, we found a 19x affinity for that provider with more information. If you have more functionality, that even goes up. Appointment setting, ER check-in ahead of time, some perceived benefit, ER wait times, et cetera. So by really providing a consumer-focused technology that levers off of those human nature factors, you start to drive market share in an area where we'll go from if there's 4 hospitals in a metro area, one of them is our customer, they'll get 25% of the searches. And if we layer on the information and functionality, they'll drive 86% of those searches. And so that market share helps for fee-for-service, so it helps their business model now. When you connect into the EMR systems, you start to engage the patient and bring the patient into that that data flow. And then as you look at moving to value, affinity and coordinated care are really important concepts, especially how consumers interact with the delivery system. So if you're getting 86% market share from your fee-for-service, that transitions really, really well into what essentially becomes a convenience network. And so we're rolling out now with MSSP programs that really can't define networks for patients, but we can provide convenient access, and that drives a lot more access to the providers that are on the hook for providing care and sharing risk.
So I think we have some time for some questions. What I would say in summary from the panel is we see an increasing opportunity of investing in the two other phases, the infrastructure EMR phase. I think it's harder for private equity or venture capital to make a dent. The installed system base, the amount of dollars that have been spent, it'd be hard to start a cable TV company from scratch, or a satellite TV company and go head-to-head with DirecTV. I think anybody trying to jump into the phase one game in terms of venture capital, private equity is going to have a hard time. But in terms of the areas that Chris, data aggregation technology, or Peter, ultimately into provider-consumer communication and connectivity, we just see an increasing amount of deal flow and opportunity, and it's really the very early days, and it's a very exciting time. Zubin, I think we have time for questions. If anybody would like.
Yeah. So just reflecting on some of the things we heard from Chuck this morning, we're also going to have a session this afternoon on risk adjustment, where it's a good example where with the phase-in of risk-adjusted reimbursement, we started a clinical auditing industry where the payers had to go out and harvest comorbid conditions out of paper charts because docs bill on a chief complaint, and the data the plans needed was the data that wasn't in the claims database. So as you think about the future with structured and unstructured data, do you see the capability, say, Chris at Precyse, what you guys are doing around NLP and computer-assisted coding as being, pretty applicable to what's going to happen with payer-provider collaboration? And, thoughts from all three of you would be great on that.
Yeah, I'll take a stab at it first. Absolutely. There is, the best data is the physician narrative on what occurred. That narrative is transcribed and then it's populated into an EMR. But that's not discrete data that is mined. What the technologies you're referring to, the NLP technology, natural language processing, does is takes all that data and tags it appropriately with clinical terms and makes it more relevant, so then it can be sent back to source systems for the analytics that you talked about and Chuck talked about. It can be sent to portals for consumers to digest and use, and it broadens the appeal of how we all engage in healthcare.
I would augment what Chris said. The best data was, or maybe currently is, the clinician narrative, but could also include the patient narrative, right? And it's on both ends of the care delivery experience, right? Before, as Pete was describing, right, the data that you're capturing about what people are looking up, what are people not seeking care about because they've looked in your app, they took care of it, and then they got better, right? Or they looked it up, they went to the ED, they went to their provider, and then we don't know, we providers, we don't know what happened, right? So it's the outcome side where we're also not currently capturing data. And there's vast opportunity in that space as well. The government has a lot of interest in that. The payers have a lot of interest in that. Because I know if I treat my patient, they're either dead or better if I don't hear from them, right? And so how can we, remember my three things, right? Capture the data, analyze it, and then do something about it, right? So with the patient information, it's how do we capture that data? And I think, Pete's product and other products like that are great opportunities for us both to learn about what happened before and after they've interacted with the healthcare delivery system.
I think one of the challenges is just, I was at organizations that had patient portals years ago, right? And a lot of the EHRs have patient portals. Is getting the patient to go. How many of you have gone out to one of your physician's portals and done something?
Yeah.
3 or 4. And we're pretty smart people that, get sick once in a while. And, we're not doing it. So we've got to figure out how to drive the compelling reason for me, you, to do that. That's what we've got to figure out.
Yeah, in a lot of cases, portals are very, if you have a really complex medical history and, you go to a large established health system, you're probably going to be engaged in that portal. If you see the urgent care down the street, a doctor across town, and occasionally get admitted at a couple different hospitals based on what your conditions were, those portals don't work. You're never going to manage. I can't manage more than one password. So having that holistic view of the healthcare delivery system and kind of standardizing access, I think is really, really important. And talking about the actuaries, I keep joking with the Aetna actuaries that's what I want to do next. But it's really probably one of the most disruptive times for that. 160-year-old company that now is trying to flip everything on its head, right, and find the sick people that you can actually make an impact with. So what are the data elements that actually define that? Nobody knows. And it may be related to social media, to your search activity, to what you spend with your credit card. So the big data opportunities there are pretty profound.
But I'd like we have a little time. I'd love this panel, and maybe Mike, who you've all had success. Tell the audience about tipping points, because from where I sit on the not-for-profit hospital, there's Cleveland Clinic, there's Geisinger, right? I think then there's the whole rest of the world that might be a quarter of a century behind some of those institutions. Literally, I believe only 16% of hospitals qualify for phase 1 meaningful use payments. So, could you point out where you see some inflection points happening in the next 12 to 36 months that we as investors could look for?
Yeah, well, two things. One, I'll just comment on just generally some things out there, and then secondly, maybe as relates to a specific investment. Or how to look at an investment, or you're at a tipping point for that investment. But generally speaking, to get to the point that you're talking about, we've had to have some catalytic events. So there was a pretty significant event in the stimulus plan that pushed for the EMR. I think another huge event is coming up, which is mandatory ICD-10 adoption. Mm-hmm. And there's obviously, I saw a number of hands go up that people had actually heard of ICD-10 as a coming standard. The irony, I would say, is that there was a delay in ICD-10. It was supposed to have been adopted already and got pushed off once by a year. Most interestingly, those leading providers, those providers that many of the people in the room would say, these are the thought leaders, these are the best run medical institutions in the country, they moved forward on ICD-10. And as I look across the Altaris portfolio and I come across other companies, those people who manage the best practices also tend to be the low-cost provider, the high-quality provider. And so I think we do have this ICD-10 event coming, which is why there's going to be a lot of spending around it. But it's the people who really absorb that into their corporate culture that's going to make the difference. In terms of your investing and that sort of thing, to me, a real, and I realize that wasn't necessary, you were asking really more the first part, but just one comment, to me, you got to get to the point where you've got enough cash flow in your business to sustain state-of-the-art R&D and still have something left over on top of that. And until you get to that point, you're somebody else's snack food. You're going to be part of the equation. So as we all go out to look for investments and set up business plans, and you're looking for that kind of tipping point, where do you get to the point where you're going to have enough cash flow to be able to be competitive? There are a lot of businesses, but there aren't that many. And in this world, the HIT world, you're either an application, snack food, or you're a business. So I'll let the others respond.
Yeah, I would add on to, but why is something a tipping point in healthcare, right? And ICD-10 is a tipping point because it has the ability to impact quality because it is so much more specific in population health, which is on the agendas of the government and us as consumers. It also is a tipping point because if you screw it up, your revenue in a health system that you're dying to keep and figure out how to grow is going to take a huge hit because of coding errors. Productivity is going to fall, coding productivity, and physician queries, or when people ask the physician, what did you mean when you said, I had surgery last week, you fixed Chris Powell's shoulder? You know, did you do this and did you do that? And that takes time for the physician. So now what's happened is there's tools that companies have developed, and we are one of those companies that developed e-learning tools with physician, going at the physician, not just the coders, the physician, the nurses, with e-learning mobile applications. And we've engaged, all these physicians in I-10 training to help them make this transition. So the quality, the revenue impact, I think make I-10 something that's going to drive change. And then even this morning, we talk a lot about Chuck's presentation because it had a lot of good stuff in it about what's happening. But the mobile aspect is another big initiative that will drive change for patients. We all have our iPhones, and some of us are busy on them now, right? Probably. But the reality is that's access that was never available for consumers, physicians, anybody in healthcare. And companies that can drive content to those constituents are going to be really successful.
If you look at the other industries like travel, auctions or garage sales or really whatever Craigslist and eBay took on. Once there was technology that really fit the consumer's need to engage in a transparent marketplace for that, it started to really take off, and it built billion-dollar companies, multi-billion-dollar companies. So I think there hasn't been that core technology yet for patients or for healthcare consumers, because healthcare happens wherever you are. It's confusing, and unfortunately, we haven't simplified the workflows for patients well enough with a lot of the technologies that have been built, and they haven't been sort of omnipresent with that patient. So whether it's Google Glass or whether it's mobile devices, I think the technology has to be built in the right way so it's simple and executable and creates that transparency. It has to be the right kind of device that's with you and that you relate to in relation to that issue. And I think once we start to get to a tipping point of distribution, which is one of the most challenging things in getting healthcare consumer technology out there. There's no virality at all. I like to say the only thing that is viral about healthcare technology distribution is just getting sick and getting a virus. People don't share that kind of technology. They don't interact in the same way. So it's very, very costly to do that. And it's a multifactorial distribution process with B2B2C and B2C and national PR and local PR and all the different things that you can leverage. Once we get to a certain point where enough people have said, these tools or technologies have given me transparent access to the data I need to manage things better, and I have better outcomes, lower costs from it, that's when I think we get to a tipping point and consumers start driving more about how we deliver healthcare.
I'd like to follow up on your point relating travel to healthcare, because I think it's a really good question. There's no question, just having clicked around on your app here and hearing you describe it, you're creating an enormous amount of value for consumers, making it easier for them to engage in a complex, multifaceted delivery system that they're not trained to engage with to start with. So you're creating a lot of value. But the question is, how do you actually capture any of that value? Because on the travel side, you had the Expedias and the Pricelines of the world. They created value. But equally, there was an existing payment structure which said you could drive 15, 17, 18% from the providers to get paid just for the referral. So how do you get paid for the value you create?
So for example, we brought a hospital in a couple months ago in Kansas, not Silicon Valley where everybody has a smartphone, although everybody mostly has a smartphone now. In the first month, we drove 400 ER visits. Each ER visit is worth $1,500 of revenue. Probably 12 to 17% of those visits got admitted, which is another $12,000 in revenue. So about $1 million in revenue for the first month of activity. And so we price based on, we don't price based on referrals because there's laws against that, but we price based on how successful we are from our analytics in engaging patients with certain facilities or providers within a market service area that is competitive. So that's how we do it. And then as you look at payers, so we bring payers on, who's in network, who's out of network. I mean, that's an easy one to drive analytics and value from. And we have a 40% reduction in ER selection when urgent care is an option. So, I've never seen stairs numbers like that before, and that's with 6 million provider searches. So people are making, based on these human nature factors that we integrate into the technology, the right decisions, for convenience and lower cost when there's validation of the clinical information.
Bob was next in the back.
So Jacob talked about the next phase, which is exchanging clinical data between different organizations. And while many of us want the data from our doctor's visit yesterday to be in our medical record today, every day you kind of read about major organizations whose data is hacked. And I wonder if the consumer really trusts the industry's ability to maintain the security of their medical data, especially when it comes to things that may be deeply personal to them, like their reproductive health or their psychiatric care or their substance abuse or that type of thing. Where does the industry have to go to really tackle that?
I'll basically say I don't think that we've established right from wrong as a nation in that area. I just think it could go either way. And I think you're correct that to be really effective, you're better off with open data, open information. But, it's ingrained in our constitutional makeup as a country, right to privacy, keeping the government out of your, certainly out of many parts of your life and medical records being an essential part of it. So I think there are parts of it that, there's a lot of consumer interactivity, connectivity that is HIPAA compliant, but there's still a lot of work to be done. I think one of the big frustrations of the Obama administration has been, to make sure that the EMR companies don't try to monetize their databases. Sort of the American public has helped pay for this connectivity. We should benefit from it. It was not designed for people to package it and harvest it as transactional revenue information. And I think that was the big topic at HIMSS this year, a couple of public announcements, and the industry is wrestling with that. So I'd let any one of the panelists want to comment on it, but my view is you've brought up a very good question, and I don't think there's a conclusive answer to it.
Well, there are laws, right? So we have laws, and some of our regulations enhance the security. Ideally, we would see the patient as holding the key, right? So as technology evolves to put you in control, so one of the requirements of the EHRs as of next January is that you have the capability to view, download, and transmit your information. So view, fine, you can see it. Download, you could stick it on your USB drive. Transmit means you can actually be the source of that data, getting from the hospital to your primary care, or from the cardiologist to your primary care, or whatever. So as the patient becomes more in control, I think that's what's going to cause us to have a better confidence in the system's ability to protect and help us manage our information. My wife didn't like the Easy Pass in her car because the government was watching where she was going. But she got over it, right? Because she didn't want to wait in the long line. And I think there's a piece of that, too, where we do give away some of our personal freedom. Do folks know about the lawsuit that involved Target and a pregnant woman? Everybody know this? So Target, because of your buying behavior, knows about your medical conditions. And so they sent a pregnant teenager congratulations about her oncoming delivery, because not only do they know because of the things you don't buy anymore, and because the things that you start buying, they know your due date. And you know, her dad found out she was pregnant and she sued. And so our health information is known, and what's fascinating is that how that can be combined with other data to know amazing things about us. But anyway.
Back.
Jacob, you spoke about RSS, and I was wondering what the administration's outlook on open source computer engineering was, and on the private side, what you guys think a catalyst like open source technology coming into healthcare IT is going to have on business models, from data aggregation to consumer healthcare companies and all types of healthcare IT companies as we move forward. Do we think there's going to be sort of a EMR 2.0 as there has been, the Web 2.0?
So we've made investments in creating products that are open source. So any product that we create is almost always by definition open source, which means that it's available for the community to take hold of. So there's a product that we created called Pop Health that is this data capture tool that I mentioned earlier. So you can catch these reports that come out of EHRs using Pop Health, and a number of states are now thinking about adopting it. The problem is that we don't provide service around that, right? So Red Hat took an open source product and created a service model, right? So you can buy your Linux from Red Hat or IBM, and so we think there are great opportunities here for companies to both augment the base software and create communities around what we've, the seeds that we've planted. And so we think that's a great opportunity for both investment and communities to get around these things.
I think Epic is leading the open source movement, aren't they?
Thank you very much.